Anyone who already had it is now going to dabble in fentanyl and might convert into kind of fentanyl use. And then, of course, there's fentanyl counterfeiting. So if you think you're getting oxycodone, you're not, you're getting fentanyl. And then, of course, it's showing up in a bag of Coke or some, meth. It's just hard to control it once it's out there. It's so potent. And such a small quantity can be so powerful. That means it's kind of just contaminating everything.
This is the Knocking Doors Down podcast. I'm your host, Jason LaChance, and here we unlock stories of resilience, triumph, and transformation. Hey, please hit that subscribe button on whatever platform you're on. And while you're at it, why not leave a rating, a review, or a thumb up on YouTube and a comment in the video. And my guest is Dr. Joshua Lee. He specializes in medication-assisted treatment for alcohol and opioid use disorders. Joshua conducts clinical trials and treats patients struggling with addiction as a primary care physician. He's also a professor at NYU Grossman School of Medicine. And through his practice, he explores the intersection of addiction treatment with innovative solutions and personal and professional growth. We discuss a variety of topics, including how Joshua didn't expect to go into addiction medicine. Also, what are some of the challenges of medication-assisted treatment? And with that, he presents how medication-assisted treatment needs an overhaul. We also discuss the overusage of our cell phones and how Joshua himself has struggled with that. And Dr. Joshua Lee shares his perspective on his own substance use throughout his life and how opioids are very seductive and the addiction can happen to anyone. We discuss all that more on this episode of Knocking Doors Down. Dr. Joshua Lee, thanks for joining me on Knocking Doors Down.
Hey, great to be here. Thanks for having me.
Oh, yeah, my pleasure. I mean, the listeners heard your credentials, so we're going to get into all kinds of things that should be really exciting and opening my eyes to a lot of things. But I always start with gratitude because me in recovery, if I don't start with gratitude, let's be honest, my days usually go to crap. So three things you're grateful for today.
Oh, man. I love the change of seasons. I'm talking to you from the Hudson Valley where we have a great, summer, fall, winter cycle that's happening now as we talk. And that makes me grateful for, to be alive and to have this time on earth that I do. Grateful for my family and that they're not here. I'm speaking to you from home and still getting used to like post-COVID professional life where a lot of this stuff now we do from home, and that's much different than what I was used to before COVID, but getting along. And then, I grateful for like my health and the work I do and the connection I can make. We're just talking from like my personal experience with drugs and alcohol to my patients and the care we're giving. And just grateful for kind of the career I've had, which I continually find like kind of fun, exciting, satisfying, despite, helping people that are in the thick of it and going through real stuff and sometimes not doing great at all, or we haven't seen you for a while and you're not looking so great when you come back to see us, but just, grateful I have the opportunity to do it and hear people's stories and hopefully help them, get back on their feet.
Yeah, absolutely. I can, that resonates with me a lot. It's really tough when you see someone kind of go back out and you really see them on a good path. And I can imagine for you, because obviously what we're seeing now in this country, I mean, opioids, it's coming out of the, thank you, the Sacklers and everything else. It's where we're at now. I mean, we're seeing it more and more, the homeless situation increasing, and it's all connected in a way.
Yeah, I agree.
Yeah, it's just, So anyways, I want to dig back on you though, because I'm curious when you started going to college for medicine, was this the area that you wanted to go into, or did it kind of start to a different trajectory take you here?
Yeah, no, not really. Addiction treatment, addiction science has been a relatively small part of like traditional American medicine or the big hospital center or the research university. Most of the focus when I was learning, medicine in med school, for me, that was in Memphis, Tennessee, at the University of Tennessee, where I grew up. So I was at my state med school. There was not a lot behavioral health or addiction. What was there often through like your psychiatry rotation, I was fascinated with and thought it was really interesting. And then when you had to choose which residency to apply to for further training after med school, I picked primary care internal medicine. So that was general medicine, kind of like family medicine, internal medicine, but with a focus on like outpatient and kind of public health and epidemiology and reading and writing and not just seeing patients. And I wanted to develop a career that wasn't just like seeing patients all the time, but was also thinking about big things and maybe doing some writing. But I didn't really know what I would do with it. I didn't wind up going into psychiatry, but that was, your primary care doctor is in a lot of ways a kind of counselor, therapist, psychiatrist, even without having like the expertise that you do get from a psychiatry training. Yeah. So that was me. I was kind of between medicine and psychiatry, just, once I got into the field, and I liked them both, but wasn't sure what to do with it. And then addiction, that came to me in part because I was working in corrections. I was really interested in New York City jails as a kind of research environment. Like, can we do a survey? Can we talk to people about Hep C? Can we talk to people about needles in Hep C? Let's go to the jail and do that, because that's where a lot of people are at, with those types of problems and behaviors. And that became a career where I worked a lot in the jail system, just as a moonlighting physician. I was there at Rikers Island or downtown in Manhattan at the Manhattan Detention Center, just doing shifts, doing kind of like primary care, urgent care. But that obviously has a lot to do with addiction. People usually aren't using substances right then and there because they're incarcerated, but they just got admitted to the jail, and so they're going through withdrawal, or they're trying to figure out what to do next, or they're about to leave, and you can actually start to plan for, or hopefully even well before they leave, start to talk about treatment, offer treatment. Do you want to go on methadone, that kind of stuff? And New York City jails have been pretty good for decades about like, we want to tackle HIV, we want to help with hepatitis C, we want to help with overdoses and HIV, and get you on methadone before you leave, so you have a better chance of survival after. And that was all like pretty exciting and kind of as I was growing up. And then it became a job at NYU, where I still working with other people more senior than me that were also doing addiction stuff. And then it was like, well, we're hiring you to go do addiction. You're going to go to primary care at Bellevue Hospital in New York, and you're going to start writing Suboxone prescriptions. And that was like one of the things I was supposed to do as a new hire. And I did it. And I'd never done it before. We were all pretty new. This was like 2005. Suboxone was approved around 2002 in the US. So this is about 2 or 3 years into Suboxone. I was new to it. The whole hospital was fairly new to it. Most patients had never heard of it. And so I became one of the like main people in this big hospital that would prescribe this medication. And we started collecting a practice of between like 100 and 250 people who would come and see us once a week, once a month, whatever it was, in primary care, not in a like licensed drug and alcohol center, but in just a regular primary care right alongside diabetes and asthma. And we were treating people, and then we wound up treating them for months and months. And then some people we've been treating for over almost like 2 decades now. I still do this work in the same clinic with some of the same patients from that 2005, 2006 year. And a lot of them are still on buprenorphine or Suboxone, right. And they've done incredibly well, and they're healthy, and they haven't used for again like over a decade. But that's how those medications work. It's also not easy to just jump off them if we're going to talk about like Suboxone or methadone. And so it's a safe, rational, reasonable plan just to stay on it essentially like for life, or till you're quite old, and then maybe you'll tackle getting off it later, or maybe you never will, but you can decide just to stay on it. We were trying to make it as easy as possible, reducing the amount of visits people had to have with us. You can give refills in New York State for buprenorphine products. So you might just see me 2 or 3 times a year by the time you were stable. Kind of like for other regular medical problems. And then along the way, we were trying to be like, hey, your blood pressure's high, or hey, you got to stop smoking, or we're going to give you the smoking lecture now. Like, what can we do about that? And, just trying to provide all purpose primary care, often to people who were not otherwise going to get a lot of that, but they were there because of the opiate problem. And that's a good result of kind of like getting everything together in one place. Kind of the idea, it was trendy to talk about this during Obamacare, the medical home, where one person, a multidisciplinary team, we got some psych, we got some infectious disease, we got your kidney, we got your methadone, and like, you don't have to go to 6 different appointments. Like, we can generally quarterback that from one place at one visit. And that's a little bit of what we've been trying to do at our practice. Yeah.
Knocking Doors Down by Carlos Vieira, now available wherever you get audiobooks.
I wasn't done partying, and I didn't want the binge to end. I think I knew that when I finally got home, I'd have to face what I had done, and I wasn't ready to do that. Being responsible for my actions wasn't something I was looking forward to. I had abandoned my wife and baby, my family, and my business. I wanted to avoid the shame of returning to what I had left behind. Even though I was not yet going home, I wasn't sure I had enough resources to continue the binge.
Click the link in the podcast description to find out more. Well, that leads me to my question. That's pretty interesting, though. You bring up, concerning maybe smoking or people that, because, I mean, there's all this speculation. We're not going to talk about, of course, with the passing of Matthew Perry and about, he had COPD and was he or wasn't he on Suboxone and a lot of these things. And it's so important that I mean, I see that as one of the great benefits that you have a patient that comes there and you can monitor all those things, because there is the drawbacks to it. It's not like you can take methadone and Suboxone and that there isn't negatives to it. It's like with any medication, there's the negatives to it, primarily, obviously, with any opioid, right? I mean, correct me if I'm wrong on this. So prescription opioids, if we're talking pill form, don't primarily affect the body per se, unless you really start to overdo it. That's when we see a lot of the bowel issues with bowel perforation and things like that. So how when you approach these folks, I mean, what is the work that you do? Let's say someone says, I want to taper. I don't want to be on Suboxone for the rest of my life, especially if it's a young person. Like, I get it if you're getting the person, because I've known and met people that have been, hey, I survived on heroin for 30 years. I'm now in my 60s. Like, I really get, like, okay, you might have another good 15 years left in your life. So I get staying on something like a Suboxone or potentially methadone, and again, I'm not a doctor, but when people have asked me, I'd be like, well, talk to your professional, but my understanding, I'd probably go the Suboxone route over the methadone, because I've known people that have tried to get off that, and it's incredibly nightmarish. What do you offer that if someone has a pathway and they're like, hey, thank you, but I want to go on a taper. I want to get off. And then still offer services post that, or does some of the things kind of tie your guys' hands that if it's like, okay, once you're off of this, like, I got to kind of refer you somewhere else, or how does that?
No, we're not like your therapist, so you're not necessarily going to come see us no matter what for years and years, but you never leave primary care. We don't kick you out. Come see me in a year for your checkup kind of thing. Like, we can be your primary care doctor. So we don't have to be like, oh, you're not doing our program, so your butt's not in our seat and you're not taking our prescription, so we're not getting paid and you can't be a client anymore. You see that a little more with like specialized drug and alcohol treatment, where like there's a business plan where like you got to be participating or they can't afford to like really, have you there. That's not the case with us, and we will help people get off it. I'll say what we know about buprenorphine and methadone is we have our good guesses, but we don't really have established the best way, and it may be different for different people anyway, to get off it, and it is hard. So that's the bad news is they're still opiates. You're still physically dependent on them, even though you're using them for maintenance purposes. You feel normal, quote unquote, when you're on the right dose of either methadone or buprenorphine. But you do have to take it regularly, every day, maybe every other day, if you're dosing it really, really carefully. So it's a daily medicine, and within a day or two of not taking it, you start to feel quite crummy. And to completely withdraw from opiates, but in particular buprenorphine and methadone, which are very long acting. That's one of the reasons we like them for treatment. They're not just constantly up and down. They're kind of this low and slow kind of up and down. That's why they kind of help regulate everything well. You can have weeks of like, I can't sleep. I have like restless leg when I'm trying to sleep. I do have cravings. My anxieties ramp back up. All sorts of kind of what we call like prolonged or kind of chronic withdrawal. That is pretty normal if you're trying to like get off methadone, even if you've carefully tapered it off. Like once it's off, there's still like a process. One exciting area though is like with buprenorphine, we now have these long-acting injectable forms of buprenorphine. And that is a shot you get in your belly, a little bit like insulin. And it forms this like piece of gum or other kind of like nodule under the skin. And that is how the medicine kind of is a reservoir, and it slowly degrades and dissolves over a month or two. And you're getting kind of a constant level of buprenorphine in your brain. And then in a month or two, you need another shot, and that keeps going to maintain on it. It gets you out of taking the medicine every day. It may also be true that if you take a shot and then quit altogether, you just have a really, really slow ramp down, and your brain doesn't even kind of notice the second, minute, or day when you kind of go off buprenorphine, because it's been like so long, so slow. And then from one moment to the next, your brain or blood levels do keep dropping, and they go to a lower level that you really you're not really on the medicine anymore. But it's taken that long that people report not really kind of noticing a withdrawal period, not instantly getting cravings back, not feeling crummy and laying around on the couch for a month, a couple. So there may be new ways to do it. We don't know the answer if these newer forms of buprenorphine are, just great at this. But if I had a patient these days who was otherwise stable, that's the other thing. We don't do it lightly.
Sure.
It's like if Suboxone or methadone are like helping you in recovery, but you're still struggling with housing, you don't have enough money, you're stressed out, your psych meds aren't totally dialed in, like you have other acute problems that you would like to get in better shape. Trying to get off this stuff is just going to really stress you out, and it's going to put you in a dangerous situation in terms of relapse or using again, et cetera, et cetera. So like there's no point to trying to get off it if it's just going to land you back on dope or whatever you were using before. And that's the conversation we try and have with everyone, like kind of like the benefit of staying on this medication is you're kind of preventing that from ever happening to you again. But when you're off it, it just makes it more likely that people are going to slip because they feel bad physically, or because they just know they can use again and that's attractive to them. Totally normal, natural. Like I want that to happen to me one more time, or I think I can handle it this time. Just makes it more, if you're on buprenorphine, it's pointless if you're on the right dose of methadone, like go use, but nothing good's going to happen. Like it's a blocker. It's generally out competing the other meds. Now it's harder to say that in the age of fentanyl, where like using on top of your methadone, people probably do feel something that they were not getting out of heroin or oxycodone. And that makes it like a little harder to keep people in treatment or to say that they're doing well in treatment. But that issue aside, it's just safer to stay on it. So you want to make sure people understand there's a risk here if you're going to stop it. But as you say, like it's not free to be on these medications. And if you're on methadone, you still have to go to a methadone clinic or an OTP, an opiate treatment program, at least initially 6 days a week to get your medication. That's quite different than other medications you and I might take for diabetes, where it's all like Walgreens and what I do at home. And buprenorphine is a little easier. It's, regulation wise, it's not as restrictive. And that's a real reason people like and choose buprenorphine in the first place. So all those things are, part of the package.
Yeah, so it's a lot to weigh out. And thank you. I wasn't really up to speed any on the injectable version of
Yeah.
Suboxone over the, I've definitely known people that have done the sublingual and, that process of it. And I mean, hey, I'm pretty bad about just taking my vitamins every day.
Right.
So,
Right.
if you got to pop something under the tongue, well, and I see an advantage here in that, like I know if someone's on methadone and you want to travel and you didn't hit your clinic and you end up somewhere else, maybe another state, let alone another country, good luck.
Yeah, it's a disaster.
Yeah, because you're going to hit that pretty quick. So that's really interesting to me that science is pushing it forward for, hey, here's the thing that's a slow release, 1 month, 2 months, whatever it is. Gives at least a little more freedom to the person, because that's where, for me, like with some of the harm reduction modalities is like, I just don't want to see someone limited to that same 2-block radius. You know what I'm saying? I mean, we know it, and with the addicts that you work with, and really give them a chance for recovery. And I think that's what we have to really kind of figure out right now. Like, what is overdoing it so they never really have to confront this issue and they just live comfortably, or whatever it is, or there's no interdiction. I mean, now we're just like, oh, they're fine, they're out there on the streets. No, these are our fellow citizens dying rapidly. I mean, we'll probably hit another peak of overdose death rates in 2023. I'm going to speculate. So, like, how do we help? Like, I mean, that's the thing. That's the hardest thing, So it's just disheartening to me. But I'm glad to see science is pushing at least a little bit more, because I've heard it far less of people going, man, now I need help for my Suboxone addiction. You know what I'm saying? But I have known people, sadly, and I don't mean to laugh, but that they're methadone addicts, and, hey, it doesn't sustain them and they can't go any higher. And so now they're back out on the streets every now and then as well. So it's a screwy system. So I'm sure you guys look at that quite frequently and go, okay, how do we continue to support this and help move someone at least to a life that is, where they feel it's worth living. They want to contribute. They want to be a part of something.
Well, that brings up a couple things. One, we were talking at the opener about like homelessness, and like that is linked to and part of people's struggles with drugs and alcohol, but is also just secularly a different problem. It's like, we do not have affordable housing like they do in other parts of the world. We treat housing differently than other kind of social and public goods, and we just make it really hard and expensive to get it. And that's really playing out throughout. And then if you are street homeless, like, your chances of survival from anything, your heart disease or your addiction, goes way down, just because you can't really live healthily and protect yourself. You're just more likely to have all this death, bad outcomes, et cetera. And that's like, so in a way, like, how do we improve overdose rates? Well, part of it would be just like building more apartments, that we can let people have, even if they can't afford them, like essentially like subsidized housing. And then the methadone tangle, where like you're always kind of roped into that clinic. Probably no one in this day and age, if you had said, okay, here's your high school project, design the methadone system for America, you would not do it how we do it now. We have this kind of legacy system from the Nixon era, from like the late 60s and 70s, which was very carceral, kind of like almost like putting you on parole. Like, you got to show up every day and show us you're swallowing the juice, and then give us 8 urines a year, and you got to do this much mandatory counseling, whether people liked it or not, whether it fit their commute, whether it was like at all, in line with their preferences. That was like not even a consideration. Whereas now we think of like patient-centered care, and how do we play up your strengths, and don't worry so much about the things you can't do, but like, let's like invest in the things you can do, and then make that part of your treatment. And what are your motivations? And like, nobody would come up with the modern methadone system. But I'm happy to say, like, not so much me, but other colleagues at NYU and nationally, like there is a lot of thinking and at least like conversation going on about that. And especially since COVID, when going in person didn't make as much sense and they couldn't really do that. And then as the opiate epidemic gets worse and worse, I like to say, like, the good news is we have great treatments and the treatments work. But the bad news is, like, I've spent my whole career trying to prescribe as much as possible of these medications, and overdose rates have gone up. We're not doing enough, or what we know works, we haven't really like scaled it to the point where it is keeping pace with like the fentanyl epidemic. So we gotta like remix the soundtrack and like think of what new ways to use old stuff like methadone, and then look for new ways in terms of new treatments, new medications. But I don't have anything to report there. So like for now, we're sticking with kind of like what we know and have, but you can think of ways to get that same stuff to more people at the same time. And that ultimately would actually probably make a difference.
Have you dug into the archives of past Knockin' Doors Down podcast episodes? The Knockin' Doors Down podcast archive is available to you for free. Check it out. Here's a snippet from when Charlie Sheen was on the podcast.
AA is not the best place for a famous atheist. I kept looking for that fucking chapter. So yeah, but it's not a one size fits all. Sure, it's like saying that we all think the same, like our brains are built the same. They're just not.
Right. Yeah.
There's such uniqueness involved.
Check out this episode and so many more in the Knockin' Doors Down archive. And while you're at it, hit that subscribe button, give this video a thumb up, leave a comment, and share with somebody else that you know will get value out of the Knockin' Doors Down podcast. I would think it would make a huge dinner, at least, I mean, you know it better than I do. Okay, you have someone on, for people that don't know, you have someone on fentanyl. You don't have a responsive individual at all. It's very much along the lines of what people, when you remember the movie with the heroin addict that just essentially nods out. And, every 2 hours now, I mean, that's my understanding, the fentanyl addict's going to want to go look for that next fix. So it's hard to get that impact in there to even open up their minds to any kind of help whatsoever. And I know the data is showing now that, like I said near the top, a heroin addict, and many of us have met the person that did heroin for 30 years. Fentanyl, we maybe got 2 years max before we lose these people. And it's a real scary situation. These are our brothers and sisters out here on the street, because that's eventually where they end up. Eventually, they didn't start there. They might have, and that's one of the things that I think we're doing a good job now of getting out there is people, is the guy under the bridge or whatever. No. These are people in affluent neighborhoods that are now eventually ending up there.
Yeah. No, I agree. It's a really bad, it's a shitty drug. It's really out of control. We cannot handle it. We as humans cannot handle fentanyl outside of like a surgery unit in a hospital, which is what it was invented for. That's my big insane idea. Is like, can we have like a UN peace conference with the cartels and just like renegotiate, bring the Sacklers back? Like, let's get back on oxycodone, and get rid of the fentanyl. That's an absurd idea, and there's a lot of problems with it. But if we could go back to pre-fentanyl, we would probably be getting somewhere and feel a lot better about our ability to control this epidemic. And with fentanyl, we do not have that ability.
Yeah, and I get what you're saying, even though you got a chuckle out of it, and I did too. It just what we know now. We probably could have attacked the opioid epidemic a lot different, knowing what we know now.
We speculate. We got rid of. It really is harder to get a pain prescription, an opiate prescription. The rate of death from prescription opiates has gone way down, even though we still use quite a bit of them compared to other countries, and kind of in proportion to like how much we probably really need. We probably still overprescribe, but it is not to the extent that it was in the 90s and 2000s. And sure enough, like death rates from oxycodone, from morphine, from Dilaudid, from these usual kind of medical opiates have gone way down and are not really a part of the opiate epidemic to the extent they used to be the defining feature of it. So that kind of worked, but it got replaced with fentanyl, and that does not work. So it's an example of like we are able to prevent it. Probably fewer kids get it after their wisdom teeth, a bottle of Percocet, and fewer of those kids, high school and college and young adult kids, will then wind up with an opiate problem. And then the different problem is anyone who already had it is now going to dabble in fentanyl and might convert into kind of fentanyl use. And then, of course, there's fentanyl counterfeiting. So if you think you're getting oxycodone, you're not, you're getting fentanyl. And then, of course, it's showing up in a bag of Coke or some, meth. It's just hard to control it once it's out there. It's so potent. And such a small quantity can be so powerful. That means it's kind of just contaminating everything. Yeah. And for now, what's going to happen? It's going to burn out. Like eventually, just everyone that's using it will find treatment or die very quickly. That's one scenario. And then you just hope that like the new users don't come online. Much like we thought that crack and meth, and those are still big problems, but we thought that was like. Think about like the crack epidemic, quote unquote, from the 80s. That was just going to destroy entire cities and wipe out kind of urban America, if not the whole country. And it didn't, in part because if your parents had a problem with crack, you did not become a crack user as a kid and then young adult. And maybe that we can do that with fentanyl, where like maybe we can educate the next generation, or they can just see the destruction and I was raised by my grandmother. My parents are not around because of this drug and I'm never going to use it. That would be another kind of long arcing but hopeful way to get out of this, is that we just don't keep recruiting new users.
Yeah, I think, and I do, I'm glad you bring that up, especially with young people, because I do speak in schools time to time, and I prefer classrooms over an auditorium. This way I get some actual conversation with these kids, and when they ask me questions, well, why did you fall into alcoholism and everything else, and at the end of the day, I say, no matter what, you're looking to change something about your nervous system. For me, it was not even knowing I had anxiety, which alcohol is a phenomenal drug for it. Afraid to go talk to the pretty girl because of rejection? No worries. I'll go talk to rejected. No worries. I'll go talk to number 2 pretty girl, whatever it is. And I explained to him, it was me trying to do something different to my nervous system. And I'm willing to bet if you talk to every other addict who's really done some work, they're going to tell you the same thing. And, for me, stems from trauma, lineage of addiction and so on, and which is common for most. But I said not everyone, especially with opioids. And I think a lot of these kids are kind of at a period in our time. It's such a weird world, especially with locking us down for years and then missing out on certain developmental stuff. And we won't go too much into that because then I'll get really mad. But I think they're really wanting to be shown a light of a different way. I think they don't want to go that way, but they want a little bit more of a light that kind of, I think, has dimmed out for this generation. I've talked to young girls that, when I say that 19, and it's like, well, I don't have any skill sets, so I guess I'll start an OnlyFans or something. It's like, come on, you've got so much more to offer than that. I'm sorry. There's so much more to life. And I don't know what it is, Doc. I don't know if it's social media, society, or the combination of all these things. I really don't know, but I'm hopeful because they are, people go, oh, teenagers are stupid. No, these kids are switched on. They're smart and they know a lot of shit that you don't.
Yeah, for sure. Yeah, I agree. I think the phone overusage and social media is bad. I don't think you can blame podcasts, but I have my own struggles with my phone and putting it down and just being present. It's hard to do. But you mentioned alcohol, which we do and want to treat alcohol. That's often a different animal, if you will, than opiates, but you can do a lot for that too. So if we got ahead, and I neglected to mention like what we like to do there, which is similar to Suboxone and methadone. We often start with naltrexone, but it's the same concept. It's like You got a health problem, I got a medication. What do? I'm a doctor, I write prescriptions. So it's like, try this drug, see if it helps you with your depression, with your smoking, with your alcohol. There's a couple that we can cycle through for alcohol, but it's the same basic idea that like we do think there are some medications that can help with this problem that traditionally people didn't think much about getting that kind of help with. But it's there too for alcohol.
Yeah. Through research is let's talk the alcoholics, because it's me, it's relatable. Is there the big four: dopamine, oxytocin, serotonin, endorphins? Do you find in the research, is there any brain scans done, or is there even any kind of tests, I don't know, that would show that some of these chemicals tend to run a little bit lower for the addict alcoholic, and that is part of the focus of treatment as well?
That's a good question. We don't have like a test, like a blood test, like a biomarker, or really like a brain scan. Like, oh, I can see your serotonin system is dampened, so we're gonna like hit you with Prozac and these other things. It is interesting. Like naltrexone is one we use a lot for alcohol. Naltrexone is a blocker of the opiate system. We can also use it for opiates, but it blocks the mu opiate receptor in your brain. That is probably central to not only enjoying or liking opiates, and for some people alcohol, but we also use it in weight loss. Like the opiate system might help mediate, I love to binge eat, or I love sugar, I love, fatty, salty stuff. That kind of what we like and don't like. And on the side of like what we like that isn't particularly healthy for us, that might come through the opiate system a little bit more than other things that we like because they're healthy. I like eating, I like water, I like getting sleep. That's all like super necessary. And your brain has to kind of like reinforce that and tell you, you need to get some rest, dude, and you need to eat some good food. That kind of stuff. Like our reward system, if you will, is there to tell us kind of what to remember, what to learn, what to repeat. But drugs and alcohol can kind of hijack that, as well as other kind of compulsive behaviors like overeating, gambling. And naltrexone is a drug that if we kind of manhole cover the opiate receptor, it just helps us. We're just not as interested. We don't get as much oomph in a second by second or daily basis from certain drugs, opiates for sure, because it's blocking that receptor. And then alcohol also, and it can help with weight loss. It can help people kind of cut down on binge eating. And then some of the drugs for smoking are antidepressants, like Zyban or Wellbutrin is labeled for depression. And then we found, like in depression treatment, that it made cigarettes take yucky, and people were not as interested in cigarettes, and they didn't want to use them as much. That's not the mechanism that Chantix works on. That's another well-known smoking drug, but there is some overlap between, like, you might have depression or anxiety or a kind of a compulsion that is kind of explained by your brain chemistry. And with these medications, we can modify that, and you don't have as much of a burning drive to drink tonight. You kind of like turn the volume down on that, and you're like, I don't care about it as much. I don't get as much out of it. I'm on this medication, I realize, and it's kind of made me not think about it as much, or I don't feel as hungry or as kind of thirsty in the kind of like, I want 3 beers and a burger. Like, that's not what you're feeling that night because of the way the medications are acting. But to your original question, we can't really tell up front who that's going to work in the best versus works okay but not great versus, doc, that didn't work at all. Like, I'm still smoking. That medication wasn't very useful. We thought for a while that we would have a genetic test for naltrexone and alcohol. There is kind of a genetic difference in some of us in regards, again, to our mu opiate receptor that's in our brain. It's where a lot of opiates do their thing, but it also is important to alcohol. And there's different types of us, and about 20 to 30% of us have one type and the rest have this other type. And if you have the one type, maybe the naltrexone will work even better. But it's not the case in the studies we've done that actually is testable and reliable. So it's back to like, these medications are generally safe, pretty cheap. affordable to the healthcare system. It's not that expensive to get me or a nurse practitioner or a physician assistant to prescribe them. And so you might as well just try them, like for your smoking, for your alcohol, for opiates. And then if it doesn't work, we got to go back to the drawing board. And maybe you do need other stuff. And I would never say that medications alone are the answer for everyone, but they're a good first step, and they're easy enough that we could just kind of shotgun them to everybody. And for the people that all they need is like access to one pill a day, that's like how we do naltrexone. Maybe that will just help that many more people that otherwise aren't getting that message, are never going to go to the doctor, are kind of unaware that there's anything that simple for their alcohol or their smoking or their opiate problem. And then it won't work for everyone. So then we need like more specialized intensive treatment, more behavioral stuff, more counseling, more trauma therapy, more psychiatric, kind of co-diagnostic, co-occurring disorder treatment. And for some people that they just need a heavier kind of like dose of a combination of things, but we don't know that up front. It's hard to say up front. I think more predictive is like trauma history. I can tell you right now, I'm depressed, doctor. Like things that you can say in addition to my drinking too much, here are the problems that I'm dealing with. And then you can probably take a step at tailoring the treatment at the front end to that individual. But we don't have any good tests in terms of like, let's do a blood test and it'll tell me exactly what you need.
Right. Well, and it also goes to show like how much we know about the brain and yet don't know about the brain, right? And it's a complex piece of machinery. I mean, thousands and thousands of years old, but still very complex in how it works. And but you did say quite a few things that are fascinating to me there. I think if we present that opportunity like that you're giving to, the suffering addict, to at least maybe kickstart them towards something. You said it yourself, is that you can't just prescribe medication alone. There's got to be, all this encompassing, the mental health side of it, really digging into that. I say, hey, based upon a long time of just reality of this thing called addiction, connecting to a positive community and a sense of faith, higher power that works through you, have been the two most impactful things. And so if we can do anything to kickstart people into that direction of really, I don't know. It's hard. I mean, from your own personal experience in life, how do you draw from it, be it either alcohol or drugs, maybe someone in your family or your own experimentation throughout life?
I have always used alcohol since high school. I still do. And I try and do it, in moderation. That doesn't always work out. So there are definitely times in my life, where I'm like interested in changing it. And that has not resulted in like treatment, or going to AA or any specific counseling. I have dabbled in naltrexone in part because we had like boxes of it laying around after one of our clinical trials. It's not a controlled substance. Right. Naltrexone is kind of generic and pretty cheap. And so I have a personal experience of using naltrexone in part because I just was curious. I've been researching it, prescribing it, and I'm like, well, what does this actually feel like? In part because I did want to drink less. On average, I wanted to not have as much to drink per day or per week or per month. And it does help with that. And then the kind of side effect I experienced was like a kind of appetite suppression and a little bit of weight loss, nothing crazy. But I mentioned that before. It has been studied for that. And it is part of one branded product for weight loss. So in that sense, I've kind of sampled my own medicine, and I kind of have that perspective on treatment. I've never been a regular smoker of cigarettes, and I've not had an opiate problem, but I've been prescribed opiates. Like I think I'm some people hate opiates. They take it, they're itchy, they're nauseous, constipated, like they don't want to ever get another shot of it. I probably had the more like I like this reaction to opiates whenever I had them. And can see kind of how easily it would be to be like, there's never, once you kind of like it, it's like opiates, you're not like instantly intoxicated. Like if you have 6 beers, I would act and smell and look different. But on opiates, at least my perspective was like, there's never a bad time for opiates. Like I want to take my kids to school, I could be on opiates. I want to like go play golf with my buddies, I could be on opiates. I want to sleep tonight, opiates are great for that. So that's quite seductive when you think of like the positive effect you anticipate from that stuff. That's just a little my own personal journey. So again, like I'm not myself officially in recovery. I certainly respect people who are and don't think for a second that it couldn't happen to me, because in a sense, like I've had these ups and downs and back and forth, especially with drinking in my case. I think I'm, in a good place now, but my wife doesn't always think that. So I'll tell you that for sure.
Well, I mean, you're in a high stress field of work that you've dedicated your life to, and it's tough. And I mean, I have the utmost empathy for it, because I know just my adopted local guy here, Arthur, that I'm like, hey, I can get you help, and he doesn't want it. I can tell primarily methamphetamines, and I've not seen anything where it's like, oh man, I hope this doesn't have fentanyl, because he's always, he's in a state of psychosis, but he's not, completely zonked out. It's tough to see, because when he's sober, he's a sweet guy. And I've talked to many medical professionals that the stresses of it and the traumas that can even happen on the job, that it's like, sometimes, I might only drink once a month or twice a month, but sometimes I have a 6-pack instead of just 1 or 2, And I get it. I understand.
Yeah, for sure. Yeah, I mean, one product I am associated with is a company called Overhaul, and our idea there is like, if you're drinking a lot, you might want to try naltrexone, but you don't know that. So we're going to like buy Google search terms or advertise on the radio or some other way of reaching you. And we're finding that like people respond to that, and they weren't sure there was help out there. They didn't understand that it was pretty simple. And once they kind of get turned on to it, you can really like start to get a lot more people to consider and then to pursue treatment. In this case, it's more like kind of an app, and it's private, and it's like a lot of these like get counseling on your phone apps that we're seeing, especially since COVID. But that's another idea too, that we need approaches that are just like kind of flood the zone. Just like we're just throwing nicotine gum at anyone we see today on the street. It's like the Red Bull car that drives around New York, like trying to get you to drink Red Bull, like, more just like kind of direct to consumer marketing, that like we have some solutions. They're pretty good. They're pretty easy. They're pretty cheap. And we have seen that with smoking. Like, you could not wait around for every doctor to talk to every patient about smoking. We were getting nowhere. And the way to do it was actually just to like advertise during Yankees games. Like, you're going to get lung cancer, but call this number. And if you called the number, they sent you nicotine gum, and they talked to you about some of these prescription medications, and they tried to get you a counselor. And that has been like very successful, along with taxing cigarettes and making them more and more expensive at the retail level, which is quite a disincentive to buy another pack. And smoking rates they're still stubbornly kind of where they're at with adults, but they're lower and lower kind of each decade. And historically, we're at like an all-time low with adult smoking in the United States. Yeah, like compared to when we were growing up, or compared to like the World War II era, like pretty much like everybody smoked. Everybody smoked, especially men. Yeah. And not to say we're not dealing with a lot of tobacco-related harms, especially in drug and alcohol treatment. We find that most people are actually smokers. Like, that's very common. And so you're often then like, well, we're doing 3 things here. Like, you drink, you're using opiates, and you smoke. You only came in for one of those, but like, can you talk to me about doing something for all those things at once, or in sequence, or whatever you want to do? But like, just to let you know that like, we don't want you to smoke anymore.
Right.
and that's tough too.
We're
hoping vaping is one way out of that. That's my personal hope, although that's a mixed bag, and
right.
There's a lot that we don't like about vaping, but If
that
you
was
could,
going to be my next question, was about the vaping. And unfortunately, I have gone to nicotine pouches because I wasn't a smoker, but I was a chewing tobacco guy. I can't think of a more disgusting habit that,
right.
oh, good God. Yeah, my girlfriend, I'm not kissing you anymore. I'm like, I don't blame you, but
Right.
it's a son of a bitch to get off, doc. Like
Yeah.
I do good about day 2, day 3, the headaches, and I'm like, oh, okay,
Yep. Yeah, well, nicotine's fascinating. It's probably a lot like caffeine. It's a mild stimulant. You can use it kind of all day long. You particularly like it when you're like need to do something and getting active or need to concentrate. But it'll hook you, but it doesn't necessarily, nicotine itself, like caffeine, doesn't necessarily kill you or give you cancer or heart disease. Too much of it all the time, yeah, that's different, like intoxication, but that's generally not how we're using it. But it's the packaging of nicotine in a cigarette or in Skull or the types of tobacco that give us cancer where we kind of went wrong. But now we know better, and so you can use forms of nicotine conceivably for the rest of your life without impacting your health, much like we use caffeine, and I use a lot, and I have no intention of quitting that either. Like there are some drugs you can do to kind of boost your mood, to affect your kind of lifestyle, that are not, terrible. And like the part of like being an adult in this conversation is like people use drugs and alcohol for good reasons, and they have good reasons for doing it. And it's a little silly to think everyone should just stop or not use it again. But like, let's use them smarter. Like, let's not fry everything. Sometimes we can saute it or steam it or eat it raw. Like, there are other ways to prepare the food here. And that's part of the nicotine story, is that maybe vaping, we don't know everything about the vaping fluid, the gel, the long-term effects, and certainly people throwing out all these lithium batteries all the time is not great for the environment. But it's like, we're pretty darn sure it's better than smoking a cigarette. So if you can convert adults who smoke to vaping, that's a big win for their health, for their lungs, for the whole country, for the taxpayer, for the healthcare system. The flip side of that, of course, is like, we don't know that people really stop smoking. They kind of go back and forth, or for a while, but then they're just likely to come back to smoking later. That's not great. And then teens, if it's taken over the middle school and the high school, and then those people, to a greater extent than they would have otherwise become adult smokers, that's bad too. In other words, like, is it promoting smoking later in life? That's not a benefit at all.
Well, I think it aligns a little bit, I think, with the ingenuity of the war on drugs. We saw the evolution of different stuff throughout, then it was pot, and it was heroin, and it was cocaine, and it's like, okay, well, these companies are going to find a different way to reach clientele. That's just how it goes with anything, you know what I'm saying? And if there's a demand for it, that's how it's going to go. You don't want it to exist? Well, I don't know, then don't buy it. You get to choose. It doesn't exist in your world in life. I mean, end of the day, I think you nailed it with personal responsibility there. I mean, we are adults. It does come back to it. Eventually we have to fully accept that, no matter the circumstances of our lives, So before we get to some fun random questions, I do want to ask you a little bit about the misconceptions around Narcan. I don't know how many times I've explained to people, it is not a treatment drug. It is simply to stop an opioid overdose. That's it, plain and simple. And then they go, what's the other thing I should know? Well, that opioid addict is going to go into a withdrawal pretty damn quick.
Yeah.
So be prepared.
Yeah. So, well, it's in. So I was talking about naltrexone, and naloxone is just a shorter acting form of the same molecule. So yes, that's how Narcan works. The same as naltrexone. Naltrexone is just a longer version of that, where it does become a treatment. In other words, if you could like inject Narcan every 10 minutes, that would be treatment, in that you would not be able to experience opiates. Hopefully you would already detox. That's how we use naltrexone for opiates, because you'll otherwise feel bad if it reverses your opiate level and you're now in withdrawal, for sure. But Narcan, it's a little corollary to like defibrillators. Like they help you survive a heart attack, but you still have heart disease. Like you still have to do something about the heart disease so you don't have a second heart attack. And we, of course, know that like a really high risk for overdose is someone who just had an overdose. So like they do seem to kind of come in waves or clusters, and if you have survived one and Narcan saved your life, it's a really important time to try and get that person more help, because that person is actually more likely to do it again. Like they've already kind of shown that they can overdose and need Narcan. That's very high risk for having it happen again, versus someone who hasn't done it that week, is using, all things being equal, the person who just overdosed is more at risk for the next event.
Yeah, I went to a meeting, an open meeting. A young man overdosed twice in one day, and he was pretty lucky. He was close to the hospital, and everybody's like, "Oh my god!" I'm like, "Why are you surprised? Welcome to it. This is the fentanyl. This is how it is. You know,
right?
I mean, and then he explained, "Yeah, I got Narcan," and then checked himself out of the hospital. Was like, "No, I'm out of here," and then went and used again, and then got Narcan again, and was back at the hospital. And it's kind of, that's the area too I'm concerned about. Thank goodness this individual didn't die. Now they're here. They're under care. What can we do with them? But it's like, where's the point where we're really helping someone and yet overstepping their rights? It's kind of that teeter-totter that I think we're in, that sucks in a lot of ways, because they're not in their right mind.
That's really complicated when you're talking about like, well, we're going to do this for you because we don't think you have capacity. You're not making decisions. You're not really an independent adult. You're kind of incompetent. But generally, we don't do that, especially if they're alert and responsive and able to walk around and sign themselves out of the hospital. Certainly, involuntary admissions that's a real niche topic, but it's been applied to addiction. Like this person can't stop drinking and shoplifting. I don't know. This was one case we were dealing with at the hospital many years ago. In this person's case, they like to go into the drugstore and drink like Listerine. It was like a really kind of odd mental health condition plus addiction. Someone who truly was not really may have been psychotic or may have had other kind of serious mental disorders, but nonetheless, they were able to say like, "Oh, you caught me," and they would just constantly get arrested. It was becoming like a NYPD Bellevue emergency room upstairs in the hospital. And so eventually, one thing is patients like that will cost your county millions of dollars a year just in services, public safety, jail time, hospital time, homeless shelter time. And people are just like, can we just keep this person in the hospital for a couple more days, and then a couple more days, and then a couple of weeks? And then, is there a way to like kind of involuntarily essentially put them in an asylum and then see if they get better, dry out. In that person's case, I don't have the like end game, what happened with them, but that has been talked about in a lot of different ways, but particularly for the kind of chronic readmitting, overdosing all the time, always in some institution, just kind of cycling around the different admission processes, but never staying anywhere for very long. And we don't have a great way to like put the brakes on that. But that an older school solution was just to be like, well, you're going to the county mental hospital, and you're not getting out till we decide you can walk safely among us again. And that feels like really Victorian, and like we don't treat people like that. It's kind of like, it's not respecting their autonomy. But in some of these cases, you're right. It's like, I don't know if they have autonomy at this point. They're just kind of like in this endless loop of dysfunction and disrupting everybody else's life. And that doesn't feel good either.
Yeah. That's like, well, then what's the gauge? What's the rubric for this? How do we, and it's such a tough debate, such a complicated issue, but anyways. All right, Doc, how about some fun random questions? We'll take it a little lighthearted now.
You got it.
All right. What is your song? So like that song either you turn to when you want to feel good, or maybe if you're like an MMA fighter that you would come out to, or, something just like, oh, I need to hear this.
Let me see. Let me look on. You really put me on the spot there. I do some country.
Oh, yeah?
I'm from Tennessee. I can't. It's hard to admit that publicly living in New York. Like I don't know anyone else that really is into country. Oh man, what should I go with? I'll tell you, when I do karaoke, I've been doing Eye of the Tiger. That's stupid old Survivor Rocky. Not saying that's a great song. It's not my song, but it's pretty good for karaoke. Or something like Johnny Cash.
There you go.
Folsom Prison. It's a good one. Ring of Fire. So I'll go with some of those.
Are you more of an old school country guy?
I like it all. I find radio country and kind of new country, it's tough. It's Nashville. It's always a formula. Every song is kind of the same. The topics covered in the lyrics are very repetitive. There's heartbreak. There's I love America. There's I love you. And that's like those are
my tractor and
yeah.
No, I'm with you. People always ask me about that. I'm like, oh yeah, I like country. Oh yeah, who's they'll name off some guy. I'm like Don Williams. They're like, who's that? I'm like, okay, well, I'm gonna leave now. And then Johnny Cash, and so I'm with you on that. All right.
But I like this. I will say I like the sound. I like the picking and the kind of instrumentals and like the bluegrass roots and the kind of folk roots. That's what I listen to. That's what I like about it.
You go and see it live, it's a different experience. That's for sure. Because it's some of those bands, like I saw Darius Rucker, God, I don't know, 4 or 5 years ago. Phenomenal band, nicest guy, Eric Church. These guys, they had phenomenal bands. But anyways, I digress. What might people be surprised to learn about you? Maybe an interest, a hobby, a talent?
Oh, man. I don't think my interests and hobbies are super surprising. Like I'm a college educated white dude. I played soccer. My kids play soccer. We like to go skiing. What else? I'll tell you, I consider myself an expert. Probably many do at this point in banh mi's or Vietnamese, sandwiches. I love like strip mall Asian.
Oh yeah.
Of all types. My latest theory is like if your Asian restaurant is next to an advanced auto part in a rundown strip mall, it's good. Like it's nine times out of 10, it's totally good, and it's probably like super cheap. So that's one of my hobbies is like driving around, commuting here or there. It's like, well, what's that one Vietnamese restaurant I have not tried yet in suburban New Jersey? I do a lot of driving back and forth between where I live and New York City, and like you're always going to find like something new like that, and that always restores my faith, in all of us as a people when you find a cool new ethnic restaurant and you love it.
Oh yeah, I'm with you. We were just visiting my mom. She had to have a hip replacement. They live about 4 hours north of us, my kids and I. And when we left, I'm like, what do you guys want to eat? Well, they love pho. And I'm like, all right, place right across the street. And it's next to the tuxedo shop. And they're like, are you sure, Dad? Best I ever had.
Yeah.
Best, hands down. It was phenomenal. So I feel you on that. All right. What's another fun one? Dinner with any one person, living or not. Who would it be and why?
Oh, man. I mean, living or not, if you're going with or not, can I have breakfast with Jesus and lunch with Stalin? Not that those are the two I would pick, but like it's a good one. Who's doing stuff right now that I'm excited about? I don't know. Like there's a guy that's given a lot of talks. They legalized drugs like in Uruguay and Portugal. Like if I had to start my own podcast and interview someone, I might start with like just the basics on how it's all gone down in those countries with so-called legalizing all drugs. And one person, I'm not going to think of their name, but they've from Portugal have given a lot of talks at like conferences and stuff. And I've heard bits and pieces, but never the whole thing. So I'd love to kind of hear that from the beginning.
Yeah, Portugal, it's interesting because people often refer to that when it's the decrim model and things like that. I'm like, well, you do understand they didn't have a methadone clinic for the first 13 years they did this, right? Like they got this shit tight before they started. Okay. And I think people missed the mark. I was thinking you were going to say somebody like Dr. Gabor Mate or somebody like that along those lines,
That'd be good too. I'm not.
Yeah.
My wife does more psychedelic stuff, and he's associated with that as well, I believe. But I've never even read that book, the Hungry Ghost book. Right? That's about like heroin and opiates.
Yeah.
That's on my list, but I haven't gotten there.
Me either. He would be interesting though. That's for sure. All right. Pet peeves. You have any pet peeves? Just stuff that irks you?
Slow drivers. I drive safe, but I don't drive super slow. What else? Talking about like the whole, like I'm addicted to my phone and social media. I moved out of the city during COVID to like a more rural part of New York State. Still commutable to the city, but it's different than where I used to live. And it's hilarious. One of the social media fixations I have now is that Nextdoor app.
Oh yeah.
All your neighbors are like, ultimately it's like who can complain about things. And that's a good example of like why we should just throw our phones in the garbage. It's like there's not a lot of, you skip over the positive stuff. Like, everyone have a great day. Here's a picture of a bird. And you go right to the like, well, if you ever went to this guy's auto shop, you'll know he's a real, he's a real a-hole. And
honey, Susie's bitching about the garbage cans again.
And then but it's like live action people arguing because you can see them by name and you know some of these people if it's a small community. Everyone. So it's just like witnessing like a argument in like the school pickup line between parents or something. And I'm fascinated by it and yet horrified that I keep looking at it.
All right.
In that it's not really like making my life better or giving me useful information. I'm just seeing people argue,
I deleted that one, so I know what you're talking about. I was like, oh God. But again, goes back to the couple thousands of years old brain that gravitate towards the danger and
that's right.
This is how we are. Oh, Doc, this has been a pleasure, and thank you for bringing not only your knowledge and your work, but your own vulnerability and sharing your personal insight and experiences. This is when I like to give you the floor. Anything that you would like to add, please tell us about the work you do and maybe how people can connect with you, find you, and
my academic home is NYU Grossman School of Medicine. You can just Google Joshua Lee NYU School of Medicine. You'll find my webpage, faculty work. The Or Health product is orhealth.com, and that is like trying to get naltrexone for alcohol use disorders in a pretty affordable, anonymous, like straight to you way. And that would kind of be the message. Like, if you didn't know it, we have a lot of safe, effective medications for a bunch of addiction problems, and they should be accessible to you with not a ton of work, but hook up some of those same websites or resources if you want some help. But like, did you know that you could try a medicine once a day to help you drink less? You probably have heard of opiate treatments, but they're there too, and don't forget about them, including methadone, which is still saving as many lives as any other medication we have on a daily basis. But just that, like, you don't have to commit to going away to rehab for 6 weeks and totally turning my life around. Like, we do want you to stop using or use a lot less, but you can kind of do it on your own terms using some of these medications, much like you would expect to do for any other medical problem. You got psoriasis, you got arthritis, you got asthma, like, you don't have to like quit your job and live your life completely differently, but you do have to like seek some treatment, and try and make some changes in terms of your lifestyle. And that's how I've approached addiction. And hopefully that's just a way to kind of phrase it and package it that makes it attractive, treatment that is to more people.
All right. Thank you, Doc. Appreciate your time.
Thanks for having me, Jason. Great to meet and hang out.
Absolutely. On that note, keep knocking doors down.